What's up, guys? It's the Basketball Doctors. I'm Dr. Marco Lopez, Doctor of Physical Therapy and Certified Strength and Conditioning Specialist.
And I'm Dr. Gabe Ignacio, Doctor of Physical Therapy, Board Certified Orthopedic Clinical Specialist. And we're both co-founders of the Basketball Doctors, and we're here with our second Q&A, just pulling questions from our last video as well as other videos that we've had, and kind of pulling the audience on like what questions you have on addition of. And just to kind of give you an idea of what this video will be on, this is going to be still focused on the knee. And we have a couple questions that we pulled that are going to be about ACL, jumper's knee, and patellar dislocation. So we'll add time stamps for the video, so just feel free to go to the description to skip to either the question or the topics that you want to get into. And if you have any questions already before we get into it, feel free to already put the comments down below. So we'll get into it and we'll go from there.
Awesome, yeah. So the first question is from @AZIM4559, is that he had a hamstring graft through his ACL reconstruction in 2011. Then it failed/torn in 2022 during football. Stage 1 and 2 are done, and he had a quad tendon for revision. And he just wanted some advice regarding that. So Gabe, what do you think?
Yeah, so a lot of times when you have, so to address the injury first, so I had an injury about 10, 11 years ago using a hamstring graft. Really common back then to use either the hamstring graft or patellar tendon. Those were kind of the standard of care, and then with more research, the patellar tendon became the standard of care, and then now like the quad tendon has become more common. And then him talking about the revision, it's hard to say when it's been that long, especially being 10, 11 years and him being an active person. So I'm assuming he had that ACL reconstruction when he was younger, maybe like in his teenage years, and then he injured it playing flag football 11 years later. So it's hard to say if it's a failed graft or it's just kind of more of a re-tear. If it was a failed graft, there's too many variables to say what caused it. There can be things like graft failure, infection, the bone site didn't hold up. Those usually happen with the first couple years when it's been this long. Could be just maybe like the graft gone weak or more lax that made him more susceptible to a re-tear, or pretty much just him re-tearing his ACL, because with playing flag football, it's a big cutting sport and can happen with non-contact or contact. So we need more information to answer this properly. So that's the injury part of it. The surgery and revision part of it, we usually defer to the surgeon because there are things that they need to look at. Especially if it's the same leg, you got to make sure there's enough bone density and bone tissue quality, because when they do the surgery, they drill through the tibia and you attach the graft between two bony prominences on the tibia and the femur. So the surgeon's got to make sure there's enough bone quality and bone density there that if they do a revision or do a resurgery, that graft will hold up. So we usually defer to the surgeon for that stuff. Any opinions on that?
Yeah, just like Gabe said, I think it's more of just a tear because it's so long, 10-year gap, and flag football, like Gabe mentioned, there's non-contact, contact. It could have been a contact injury. We don't know the specifics of it. So with those, you could have had an ACL 20 years ago, or you could have been in the best shape, but if someone hits you at the wrong spot, the wrong time, you just get those contact injuries. But like Gabe mentioned, it's very dependent on the individual after their first ACL. I've seen people in the clinic where they have the opposite leg a graft. So let's say they had the quad tendon of the opposite knee, or sometimes they use the same knee, but it depends on several scenarios, because if you get the quad tendon of the opposite knee, then you're having issues on both knees now early on. But yeah, there's a lot of variables here, but I think big main point is take your time with your rehab, approach it pretty hard. And there is big differences in the rehab between 2011 and 2022. So there's more research now with different, how you can progress it and everything. So just staying up to date and then working on your mobility. Like you said, he's stage 1, stage 2, and now working on that strength to get back into dynamic activities.
Yeah, just to piggyback off that a little bit more, the most important thing is the rehab after surgery, whether it's a revision, new surgery, or whatnot. And the good part is, for the situation, is that you've gone through it before. So we've worked with people who've had either a second ACL surgery or revision or whatever, and their confidence, their expectations, and their ability to pick up exercises a lot faster than the first time. So it's kind of ones where you've gone through it, you've been through it. It's not your first rodeo, so people's expectations and their progression through this type of rehab, pending obviously the surgery and like their response to surgery, can be different. But for the most part, they know what to expect and know what to do and know how much to push. So it tends to be a little bit easier for them early on, at least dealing with the surgery.
No, 100% agree. It's, even though it kind of sucks, it's definitely easier for sure. That moves on to the next question here by at Asian Matt 2012. How can I manage meniscus pain as I progress through plyometrics? I typically get pain after jumping, not during lifting. And it's like the meniscus and ACL. He had ACL surgery, but also having some meniscus issues. But what do you think, Gabe, on this?
So he's probably in his later stage of rehab, following meniscus repair, ACL reconstruction. So it is a fine balance of knowing how to progress into plyometric and how to get started into it. And that's where you have to really rely on either a healthcare specialist or someone who's done rehab with working with these types of athletes, because in the physical therapy world, a lot of times when you get to this stage, a lot of insurance companies pretty much cut you off from insurance. So that's where we see a lot of our clients when they're kind of past the initial rehab and like looking to return to performance, return to play. And we usually start plyometric training usually kind of around this time they get cleared to jog. We start some like deceleration work in terms of like landing mechanics, eccentric work, or like essentially like decelerating or negatives, because we are on the very big side of working on your brakes before you work on the gas. So we're not necessarily jumping yet at that early, like 3 to 4 months. We usually start jumping more in like when they get cleared for cutting, essentially around that like 5-6 month mark. Just to give you guys time frames, and we don't treat based on time frame, we treat based on like their functional level, are they meeting milestones, things like that, just to preface you guys. So that's why we're kind of talking in this kind of roundabout way, because we don't like giving time frames, but those are the big milestone time frames, and we like working on like shock absorption essentially. So that's what deceleration negatives are. So like, just to give you an example, like snap downs, double leg, progressing to single leg, really working on mechanics and that shock absorption mechanics. And then from there, if you have no pain, good mechanics, you look solid, you seem comfortable, then we add a little bit more load to that shock absorption. So we either do depth drops, not the depth jump, so you're just going on a box and dropping off, starting with double leg, progressing to single leg, and then you could add like a medicine ball slam with that. So there's different progressions you can do, but we usually work on shock absorption first. And then once you get good with that, then we start adding the concentric or the power development part of it. And that's when you do like box jumps. So starting on the ground, exploding up, landing on 2 legs on a box, because that pretty much takes away the shock absorption part of it, and you just focus on power development. And you could start small, like an 8-inch box, work your way up to like a 12, 24-inch, and you're just focusing on the concentric part of it. And then kind of the in between the concentric and the shock absorption phase, we do like low intensity, high amplitude plyometrics, which is like pogos essentially, or like jump roping. Start with double leg, progress to single leg, and really managing how you're feeling. So with him, with the meniscus repair, you're really worried about like the cartilage, making sure there is that buildup of tolerance in that tissue. So that's why we do shock absorption, and then doing the low intensity, high amplitude plyometrics, and then the concentric of the power development of jumping onto a box. And then from there, once you're good with that, then you could start doing like your normal counter movement jumps, squat jumps, all the different forms of plyometrics, and then going into lateral and rotational components of it. But we usually strictly work on vertical first and then add in the other layers as they develop over time. That's kind of what we usually like to start off with. We could go on for days about this, but Marco, anything to add on top of that?
I think you hit all the points. I think the other thing that I would mention is just, Gabe mentioned pain, but also swelling. If the knee swells up, that means you did too much, you progressed too fast. And this is a topic, and we made some videos on this, on just like returning back to jumping, running, but this is a very critical phase, because if you progress too fast and you start having some patellofemoral issues in the kneecap, or if you had a quad tendon or patellar tendon, you might have some jumper's knee because you're just loading the tendon if you're not ready. So that's why the progressions are key. Like Gabe just gave you like a gem right now, the whole thing on how to progress properly. But within those progressions, there's even more micro progressions to get to that stage. So just remember, when you go there, and if you have pain, swelling, you're probably progressing too fast, too soon. And just seek out for us. We do online consultations or help out locally here in Los Angeles area or Orange County in California. But big thing is, like Gabe mentioned, work on first the deceleration, the negative stuff, because that's where all the injuries occur, and it helps your body prime the movement. It's like benching, you know, in order to get to that higher weight, you focus on your negatives. You know, you hold the weight and slowly bring it down, and this is where we're prepping our body so we can go into more movements. But that's all I wanted to add.
Yeah, I mean, that's huge, and Marco nailed it. It's like, as much as that focus of the question was on plyometrics, you're still treating the person as a whole. And like when we're doing plyometrics, we're also doing a bunch of other stuff like tendon health, ankle mobility, like all of the other stuff that goes along with it. But just focusing on plyometrics, that's kind of the mindset to have around it. And Marco's absolutely right with making sure you're checking in with yourself, checking with your healthcare provider on like how you're actually feeling and how your knee's responding to everything.
For sure. No, that was good. Let's go into the next question. Is IT band tenodesis pain exercises to help alleviate alleviate pain after ACL surgery. So what are you thinking, Gabe, for this?
Okay, so IT band tenodesis is, for those of you that don't know what that is, not often, but sometimes when people have ACL reconstruction, some people have lateral instability. So what happens is that they pretty much tighten up or use the IT band to help provide extra support on the lateral aspect of the knee. So it's pretty much like an extra layer of stability when you have ACL reconstruction. Typically happens a lot more when like for younger age athletes, like usually like the adolescent age, or sometimes if people just have to be more lax than quote unquote normal, then they might do the IT band tenodesis to help provide that stability. So just to give you guys a little reference of what that is. But in terms of to get into the question of how to alleviate pain, I don't know if you guys heard of like IT band syndrome or what's the other word for or patellofemoral pain. It's pretty much treated relatively similar. You're pretty much trying to offload that lateral aspect of the knee. So like the IT band, for those that don't know, is the tendon of a TFL, tensor fasciae lata. That's a hip muscle kind of in the front outside part of the hip. But the IT band doesn't act like a normal tendon. It's very thick and dense, so like foam rolling it, trying to stretch specifically the IT band doesn't really work. I think there's been research, like the iconic one of like someone hanging like a different pounds of weights on the IT band for like days on end, and there was like no stretch to it. So stretching the IT band doesn't really do much. What you want to do though is stretch out and roll out the muscles that attach to the IT band. So like your vastus lateralis, your lateral quad, your hamstring, getting into the TFL, your lateral glute, because all of that attaches to the IT band. So stretching those out will secondarily loosen up the lateral aspect of the knee. And then after you kind of mobilize and stretch that out, then you want to activate structures that'll offload the IT band or help provide stability at the lateral part of the knee. So that's like your lateral glute, strengthen up your quads, hamstrings, calf, working on like balance and stability training. So The treatment for the IT band tenodesis looks very similar to like treating IT band syndrome or patellofemoral pain. To answer this question, so gave you kind of tidbits there. If you have more questions, please ask them down below. But Mark, do you have anything to add?
I think Gabe covered most of it. It's, you know, addressing it like IT band syndrome, patellofemoral pain syndrome. And I think the biggest thing is people always talk about like, oh, my IT band's tight, and it's going to be tight on everyone. And foam rolling won't help. Like we've seen it in the cadaver lab. It's, you know, it's a big fibrous band. It's not moving at all. So, you know, loosening up the structures adjacent to it and then addressing the strength issues, I think that's the biggest thing that we want to address.
Yeah. And then also like kneecap mobility.
Oh yeah, kneecap mobility. Get some medial toe.
Mm-hmm. So a lot of times that IT band attaches to the outside part of the kneecap. So a lot of times when someone is coming in with those syndromes, we try and do a little bit of like kneecap mobilizations, or maybe like a little bit of scraping around that area, just to help give that tissue a chance to be able to move in that aspect. And some of the good amount of times that alleviates, at least decreases some of their symptoms.
No, for sure. Yeah, well, we have one last ACL question here. So at ASYI5TC, what graft to choose as an 18-year-old with goal to play basketball? His ortho recommended patellar tendon, but he's worried that his patellar tendon will give him issues or kneecap pain as he gets older. So Gabe, what do you think about this one?
Yeah, I mean, great question. Especially as an 18-year-old, obviously he takes his body and the sport of basketball really seriously, because asking that question shows that he's been doing his research and looking around and making sure he's making the right move. But getting to this question of patellar tendon and kneecap pain and essentially knee pain with that stuff, it is the biggest question that we get between graft choices. Patellar tendon still being the gold standard, but with the quad tendon being more common and getting more research, that essentially the two in terms of risk of failure are essentially the same, and that's really good in terms of like having confidence in your graft. The biggest difference between the quad tendon and the patellar tendon is that the quad tendon, by research and what we see in the clinic, is that it tends to have less pain in the kneecap and less pain with kneeling. And the reason is that with the patellar tendon, so for those that you don't know, patellar tendon is pretty much an extension of the quad tendon. So the quadriceps attaches to the kneecap, and then from the kneecap to like your tibia. In between the kneecap and the tibia, the bottom leg bone, is the patellar tendon, and the top one from the kneecap to the quad muscle is the quadriceps tendon. And in the patellar tendon, what makes it the gold standard before is that it's bone tendon bone. So they take a little bit of the kneecap, the patellar tendon, and then part of the tibia, and then they use that to create the new ACL graft. And the reason why there's a little bit more knee pain and kneecap pain, especially with kneeling, is that when you remove those bones, when that bone heals back, your body produces more bone in an area that's damaged or an area that's injured. So there's a little bit more trauma to that area. That's why there's more pain there. So there is that risk of taking the patellar tendon. With the quad tendon, it's not bone tendon bone. It's more of like your typical graft like they use from like a hamstring, Achilles, or cadaver. So that's why there's less associated knee pain. Risk with both of them is that you have a higher risk of like tendinopathy issues or tendinitis, because you're taking away a big muscle that is used for your extension with walk. It's like the biggest muscle that you use for almost everyday stuff. So there is that risk, but if you're weighing between quad tendon and patellar tendon, people tend to go towards quad tendon because of the less pain with rehab initially. Long-term wise, not real much of a difference from what we've seen so far.
No,
any thoughts?
For sure. I think he's doing well regardless. You know, he's going to use a patellar tendon or, you know, quad tendon, either or patellar tendon or quad tendon. We're big, you know, fans of those. And then he'll do well because he's already reaching out, you know, thinking about long-term effects. So he'll be on top of his rehab. Biggest thing, it goes back to I think the second question on like progression for plyometrics. That's where we see a lot of the tendinopathy, where people kind of go too fast, too soon into like jumping, running, and they don't have the base strength because, like Gabe said, you lose part of that tendon. So now you are at risk for that tendinopathy because you used to have, let's say, the full tendon, now you have 2/3 of it. We'll just throw some numbers, 1/3. So now all that force gets transmitted in 2/3. So now you have to slowly build that tendon up to get, stronger in that position. So regardless what he chooses, I think he'll do well because he's proactive in his rehab and researching. But, the side effects are very small. The kneecap pain, that hurts initially for the first 3 months, maybe, 4 max. And then with the tendon issue, as long as you properly rehab, you'll be in a good position.
Yeah, I think just to wrap it up with that question, it's at the end of the day, the most important thing is the rehab after.
Yeah, 100%.
Obviously pending like surgery went well, all that consideration. Like if you're with a good rehab specialist and working with the proper person, your rehab, that's the most important part.
Yeah, for sure, 100%.
Sweet. So I think that's all of the ACL questions. We're going to get into jumper's knee and a little bit of patellar dislocations or subluxations now. So we're getting into jumper's knee. We're going to flip the script a little bit. I'm going to ask the questions and Marco's going to start us off. So the first question for jumper's knee, which is a good one, get a lot, was at post clarity 00. Can I work out with jumper's knee?
That's a great question, and this is a very common question we get asked, and I'll make a separate video on this to go into more detail, but I'll just give a quick little rundown of it. But honestly, it depends, but most likely you can. There's like a 95% chance you can. There's only severe cases that we would say like don't, take it easy, depends on your severity plane. And the reason I say that is because when you don't work out with jumper's knee, so we got to understand what jumper's knee is. It's not necessarily a inflammatory issue, it's more overuse, chronic, so there's not so much inflammation there. So what happens is if we stop working out, our leg gets weaker. When our leg gets weaker, that's why you see the famous thing was like, hey, I rested for 3 weeks and I came back and my jumper's knee flared up again. What's going on? I thought it was just inflammation. Because it's not inflammation, it's a chronic overuse of the tendon. So what we have to do is we want to still continue working out, but we have to follow some couple guidelines. One of them is a 24-hour soreness / pain rule that I like to use. So meaning you play basketball, let's say you do your normal thing, you play basketball, you work out or whatever, then you have, you're having some pain there. Let's just say your pain level is a 3. And I tell people, try to keep your pain level less than a 3 or a 4. If it's more than a 4, then we have to start looking into resting a little bit and then modifying some activities. Maybe you don't play as much. But let's just say base level, you're playing and you have a pain of a 3 or a 4. And then the next day you wake up and your tendon's sore. You're like, oh man, my tendon's sore and my pain's a little bit higher. It's like a 5. That means you did too much. So you have to go over this 24-hour rule where it's like, okay, I'm sore, my tendon hurts more than usual, then you did too much in the previous session. So if you want to play basketball again, you would want to play basketball, but you want to go a little bit less than what you did the previous day, or keep it at what you did. So you can't go higher. So if you played 1 hour yesterday and you want to play again today, but your soreness is increased, you're like, I'm more sore than usual. So you kind of have to use a 24-hour soreness, meaning like, what's your soreness every day, like when you wake up? So if you're more sore today than you were yesterday, and yesterday you played an hour, so today, if you want to play basketball, you want to keep it at an hour max or play a little bit less, okay? Or even, I would even sometimes tell people, hey, take it off or play 30 minutes, even less, half the time, or just wait till the next day. So if you're in the aggressive side, if you're like, hey, I have to play, then you want to play the same amount or less, okay? However, if the next day, let's say yesterday you played an hour and today you feel good, no soreness, no pain, maybe a 1 or a 2 in the pain, you have pain but it's less than your normal pain or the same, but there's no soreness, then you could increase it, you could bump it up, meaning like you played yesterday an hour, today you could play an hour and 10 minutes or an hour and 20 minutes, so you could bump it up. And another scenario is you played yesterday like an hour and today you're like right at the borderline, you know how I mentioned in the first scenario, you're more sore than usual and more pain than usual, I usually tell people, hey, back off of it. But if you have to play, just keep it at the same time. Don't go overhead. If you have less pain, then you can increase. But if you're at that neutral state where like you had the same soreness, same pain than before, now you could be, it depends if you're in the aggressive side or in the normal side. So if you're in the season, then you could bump it up a little bit, okay? I'm okay with that. Or you want to keep it the same. So you played an hour, keep it an hour, or you could bump it up a little bit depending on what part of the season you are. Because jumper's knee, there's a lot of variables, is it in season or out of season? When in season, there's not so much room, for you to kind of decide on how much rest, because you have to play through it. But that's what I usually tell people. It's like you want to play through it, but you want to be smart when you're playing through it. You don't want to overload it. So kind of just to recap is always use that 24-hour rule. So if you're sore the next day after your workout more than usual, or you have more pain more than usual, and it doesn't go away before your workout starts, then you want to decrease the amount of minutes you played compared to the day before, decrease the load. Or if you're in the aggressive side, you have to play, you're like, hey, I need to get ready, keep it at the same, don't increase it. But if you have no soreness, no pain, then you could keep on increasing it. So it's all based on your internal dialogue, how you feel on that. And that's kind of like, and we'll make a bigger video discussing more about that, but that's kind of a quick rundown. Gabe, you have any?
Yeah, I think in terms of like training and playing, Marco's right on top of the points of using that soreness level and checking in with yourself and being honest with yourself. I think that's the hardest part is like athletes and us being healthcare providers of always having that conversation with players to be honest with themselves. Obviously, as an athlete, you want to always play, you always want to be out there, but you got to prioritize your body. And then obviously Marco just focused on the basketball workout part of it, but just know that just playing basketball won't fix your jumper's knee issue. And Marco will get into this with the future video, and you could also check out other videos we have on jumper's knee. We'll put the link in description. But you got to be doing rehab and workouts outside of basketball that actually get this thing right. Like just playing basketball and managing your minutes will help, but it won't necessarily fix the problem. You're pretty much 100%. Just like kind of putting a band-aid or like putting it off a little bit. Like if you're in season, that makes sense. But you got to do rehab and other workouts to actually address the issue. No,
yeah, that's one thing that I left out, and we'll talk more about it in that other video, but you have to be doing your rehab. This entire time, the rehab is a non-negotiable. You have to be doing it. The progression, the exercises, you have to be loading up that tendon, and we have a great 8-week jumper's knee rehab program. It's all online. If you check out our website, thebasketballdoctors.com, great program for you to do while you're kind of managing this 24-hour soreness and pain rule.
Sweet. Yeah. So the next question, I think you kind of addressed it a little bit, but it's from Oliver Fu. Why doesn't ice help with jumper's knee?
Yeah, great question. And this is something that we get asked all the time. It's like, I'm icing it, it doesn't help. I ice it every day after practice. And it's like I mentioned, the jumper's knee itself is more of a chronic issue. So icing, I kind of like icing a little bit, like 1 or 2 minutes on the tendon itself after, just to like cool it down, calm it down. But icing's not gonna do its job. You're gonna have to do the rehab because it's not an inflammatory issue. You wanna start getting the tendon stronger. And sometimes ice is a little bit contraindicated because we want some new changes in that property of the tendon. And, we're creating, we're increasing the load on the tendon. It's kind of like muscle working out. You don't want to put ice on your biceps after you do a bunch of bicep curls because you want that change. You want that inflammatory process a little bit to happen. So that's what happens with the patellar tendon. There is a little inflammatory process after you're loading it. So ice may be contraindicated, but if it's very painful, if you're like, oh, it hurts too much, then ice is a good, quick, short-term, ice it down for 1 or 2 minutes, but then still do your rehab exercises. But it's not your solution. It's just like a quick little, calming it down. But I'm not a big fan. It's there's different scenarios. Like I said, we want inflammatory changes in the tendon because we want it to get stronger after you work out. But it's okay to do some active cooling where you're just ice, rolling the tendon, for a minute or two. But icing the whole knee and thinking that's going to be your solution is not the answer. What do you think, Gabe?
Yeah, I'm on the same boat. And for us, just to round it off a little bit, it's always the question of why. That's how we work, that's how we treat. It's like, why are you doing a certain thing? And the question I think is like, why are you icing your knee for jumper's knee? I think for pain, 100%.
Yeah.
If you're icing it because it's inflamed, probably not the smartest idea.
Yeah.
So that's our why with icing, is if it's for an analgesic effect or pain relief, quick short term. Like if it's one of those days where it's like really bugging you, where it's like walking around, going up and down stairs, not comfortable for you, might throw some ice on there to help alleviate some of that pain, and then see if that helps you either get through your day, get through some movements. But always comes down to the why for us.
Exactly. Find out the why, and then last thing to add in, it's like a lot of people, like Gabe said, you know, a lot of people are against ice, but you know, sometimes you need it for an analgesic effect. If I'm able to ice your tendon and then you're able to do your exercises, that's a win for us, you know?
Yeah, we could go on a whole little spiel about icing and all that stuff.
It's not your enemy.
Yeah. Okay, so if you have any other questions for jumper's knee, those were the kind of two most common ones that we saw from other videos and stuff. Feel free to put some questions down below, and then like I said, we'll add into the description of some other videos to check out, as well as our jumper's knee program if you want to take a look at that. The last topic we're going to get into is patellar subluxations, and the one that we have is by @Manyman786. They stated that they got a kneecap dislocation on November 11th, but cannot bend more than 35 degrees. Should I try to bend it more?
Yeah, so this is a tricky one. So kneecap dislocation, just a quick recap, and we're actually going to make a video on kneecap dislocations, but the kneecap will dislocate laterally, okay? So when it dislocates laterally, you know, it'll pop back in place most of the time, crossing your fingers, you know. Majority of the time, you just extend your knee and it'll just pop back in. But when that happens, usually I tell people, sometimes you want to keep it kind of stiff sometimes, because you are prone for that kneecap to keep dislocating, especially if you injured this ligament called the MPFL, the medial patellofemoral ligament, which provides stability to the kneecap medially. So he's saying he dislocated it on 11/11, so over 6 weeks ago from the filming of this video, and he can't bend it more than 35 degrees. So it's hard to say, you know, we have to evaluate it, but what's preventing you from bending it more than 35 degrees? Is it muscular? Are your muscles guarding you for protecting it from not bending more? Is it joint? Did the knee just get super stiff? In 6 weeks, the knee could get stiff, you know, the joint itself. Another thing too with kneecap dislocations, honestly, I don't like really forcing the knee to bend too much early on. I just let it come naturally. You know, you do some active movements, because if I go in there and try to manually bend your knee more, it might slip out. I've seen it a couple times because you try to force it. So I like just kind of like active movements of bending. So meaning like maybe doing a TRX assisted squat, or like, you know, you controlling your motion, bending your knee. That's what I've seen works best. That way you kind of like slowly work on the bending, but not being aggressive, but being, you know, slightly progressing your aggression on bending your knee, because we don't want is your knee, you know, it getting super stiff, then you can't bend it, you know. So it's like that fine balance of not being aggressive and not being too easy on your knee, because if you are too aggressive, it might slip out again. If you're, you know, too conservative, your knee might not bend, it might get stuck there stiff. What do you think, Gabe?
Yeah, I mean, it's hard to say, because like a big thing, like working in acute sports, when you can't bend a knee past like 60 to 90 degrees, you're worried about like structural issues, especially since it was a traumatic issue. I'm not sure what caused the dislocation, but you also want to make sure you don't have any bony like break-offs floating in the joint. That's what's preventing them from bending. Maybe like a cartilage issue at like underneath the patella, or maybe even in the meniscus that's not allowing the knee to bend. So like Marco said in the first part, we got to know more information, and he's just trying to get to like trying to bend it. Yeah. But if you're stuck at 35 degrees, and whenever you ask this question, like I would make sure you go see a healthcare provider, make sure there's nothing more serious going on, and if there's nothing, then it's like working on gradually bending the knee. Like Marco said, don't want to get overly aggressive, but you want to be progressive, either week to week. For sure, week to week, day to day can be hit or miss. but you do want to be actively working on it. But you don't want to push it to a point when you're like forcing that knee to try and bend.
Yeah.
It's got to be smart with your rehab. Work with someone. I know a lot of you guys want to do it yourselves, which I totally understand. But you also got to be smart when you know things aren't working for yourself, or you have really of these questions where you potentially might be harming yourself. That's when you really got to make sure you're seeing the right people and just get it done, just so that one, it gets you going in the right direction, and two, put your mind at ease. A lot of times that's maybe even just one session can get you to where you need to be, type of thing. So I respect people trying to do it themselves and learning and researching as much as you can, but sometimes you just need to see a specialist or an expert to get things done. But just my perspective.
No, yeah, that's a good way to kind of just end those things. One of the biggest things I see is a lot of people use the online. This is just more for, just general information. Everyone's very specific. Even though, like, I know sometimes they're like, oh man, I was doing the right thing, but just the validation of us telling you, like, hey, you are doing the right thing, because you don't want to be doing the wrong thing, and then it puts you one step back, and that just saves you time too. You don't want to be, going, like, there's also, like, you become a Google doctor, like, oh, I have this injury, I have that, and it's just information overload now on the internet. So that's why we try to make it straight to the point, give you guys just general information. And I usually tell people, try to get specific. Even like Gabe said, like we see a lot of people just for one session, because we give them the right tools, like, hey, this is what you need to do, maybe add in this, or maybe you were doing it wrong, or maybe you thought you were having this issue. Like, a lot of times we think we have jumper's knee, but we actually have patellofemoral pain syndrome, for example, which is very different. And then in regards to ACL, they're like, hey, you know what, like Gabe mentioned, on the jumping progression, we see a lot of people, hey, I'm running, I still have pain. It's like, oh, because we didn't progress as fast, because we were thinking, oh, we could run at 3 months, but we shouldn't.
You're not ready, yeah.
Yeah. So, I mean, based on that, if you guys have any questions, comment below in this video. We'll try to answer video questions with videos. Also, send us an email at admin@thebasketballdoctors.com. And then if you want to work with us, we work with people online or also in person in Southern California. Yeah, that's about it. What do you think?
Yeah, appreciate you guys tuning in. If you stuck through the whole thing, we appreciate it. Please hit that like, subscribe button. Help us reach more. Yeah, help us reach more hoopers. We're just trying to give you guys as much information as possible. We're trying this out with the Q&As. Got good feedback, and the more questions you guys ask us, the more we'll be able to answer. We're just gonna try and grow this over time, and we'll put in the description all the stuff that we said we would. And yeah, we appreciate you sticking by, and we're the Basketball Doctors. Basketball for life.